Right. So this is the last session for morphology before spring FRCPath Part 2 exam. I would like the FRCPath Part 2 candidates to participate actively. Next Sunday we will have last minute advice for FRCPath Part 2 candidates. There will be no morphology, and then we will resume our morphology in April. So let's go to our first case. If there is anyone waiting in the waiting room, please let them in. This is a 7-year-old child that presented to ED because of epistaxis, and he has previous multiple episodes of epistaxis as well. Okay. So this is power 10 for the child. And now I will show you power 50. Yes. Any of the part 2 candidate?
No. So the peripheral blood film.
So the first question for you is, let's say you are sitting in a FRCPath exam. The first question is report the blood film.
Okay. So the peripheral blood film showing the platelets. The platelets, and there's a thrombocytopenia. However, there are large platelets. Platelets are large in size, and some are very giant in size. The granularity is okay, and there is no abnormal cell scenes, and the WBC neutrophil are evident, and there is no inclusions in the neutrophil. And in the red cells are normochromic, normocytic. Some are macrocytic, and there is N-isocytosis as well, and no Howell Joel bodies has been seen, and macrocyte seen.
If you have no Howell Jolly body, do not mention it.
Acha, okay. Atypical lymphocyte.
Right.
And
So
the findings are suggestive of Bernard-Soler syndrome. We can say, right? The findings are suggestive of Bernard-Soler syndrome.
you will fail this short question if you say this is Bernard-Soler syndrome. How do you know that this is Bernard-Soler syndrome on a blood film?
So we will say inherited, no, not inherited as well. What will we say? Inherited?
There's a macrothrombocytopenia in this patient, which has multiple causes. So the impression is macrothrombocytopenia, and we need to do further tests in this patient to exclude inherited bleeding disorders or acquired bleeding disorder. This looks like inherited because this is a 7-year-old child and he has multiple episodes of epistaxis and bleeding. And platelets are large and they are the patient is thrombocytopenic. Okay. What test you will do next in this patient?
So the additional test we will investigate for flow cytometry for CD42B and
I have not told you full blood count. So start from the basic one.
okay. So we'll start with the CBC and then flow cytometry and flow cytometry are there can be genetic studies.
What do you want to check in the flow cytometry in the CBC?
In the CBC, there will be thrombocytopenia. There will be no underlying any abnormal cell or inclusions in the neutrophil. And the true thrombocytopenia, the size of the neutrophil, the granularity, the size of the platelets, the granularity of the platelets. And in the CBC, we will check MPV.
Mm-hmm. Then next test. CBC and MPV has been done. Next test.
Immunoflow
Anything before that?
peripheral smear has already done. So,
Would you do blood transmission aggregometry?
yeah, okay. Light transmission aggregometry, yes.
Then you would say, I will go for flow cytometry and genetic studies. This patient is bleeding. What is the acute treatment?
The active treatment will involve the patient transaminic acid, and if patient is severely bleeding, then we can have an HLA matched platelets
Actually, match platelet
transfusion.
take 10 days to come to the hospital. This patient is bleeding acutely. What you will
Novo
do?
7, recombinant Novo 7 is an option. Transaminic acid and recombinant Novo 7.
Local Myers, Envoli, NT, tranexamic acid, Novo 7, random platelet. Actually, match platelets, I have told you before multiple times, it takes many days to come to the hospital.
Yes.
These will be considered as blunder and you will fail your short question. Okay. So this is not Bernard-Soler syndrome. You cannot diagnose anything on the blood film. They can only tell you the possibility that this is acute leukemia, this is APML likely, this is macrothrombocytopenia, this is likely Gray-Platelet syndrome, this is likely ALL. Rest everything you confirm on investigations. This is a second case. Another 30-year-old male patient with um, epistaxis. This is power 10. Now I'm going to power 50. Okay, so who is going for part 2 next? So to report this blood film. Lee, Carmen Lee, can you hear us?
Hello, hello. Can you hear me?
Yes.
Sorry, I just want the repeat of the stamp piece. Very quickly.
Mhm. So this is a 30-year-old young man
Yep.
presented to ED with epistaxis.
Okay. Right.
Full blood
So,
count shows hemoglobin of 110,
yep,
white cell count of 21,
yep,
and platelet count of 55.
yep. Okay. So the peripheral blood shows abnormal, large promyelocytes with high NC ratio, bilobed nuclei, presence of granules, and in some of the cells, I'm not entirely sure, but I think I saw some R rods as well, prominent nucleoli, and the red cells show anisole poikilocytosis with presence of red cell fragments, some spherocytes and polychromasia, and genuine thrombocytopenia. The features are suspicious of acute promyelocytic leukemia with coexisting microangiopathic hemolytic anemia.
Mhm. And
So this in the to finish the report, I would put this is a medical emergency and the patient should be started on ATRA as soon as possible and with aggressive transfusion to correct the thrombocytopenia and coagulopathy. This patient need urgent medical review. I mean, urgent hematology review.
this is a hematological emergency, not medical emergency. Medical team will not do anything for the patient. Okay.
Yeah.
So you
Okay.
have reported correctly. What type of APML is this? High risk or low risk, and why?
So if the white count is above 10, and it would be high risk. If the white count is below 10, but the platelet is below 40, it is intermediate risk. If the white count is below 10 and the platelet is below 40, it is low risk because the white count was above 10 in this case. Am I correct? I forgot.
Yeah. You
Yes,
can see
so
that there are a lot of white
yeah,
cells in.
and I think in the blood film, it's likely to be a case with a high count. So this patient would be at high risk. And we should consider cytoreduction, arrange baseline evaluation prior to starting of chemotherapy, likely anthracycline. So this patient would require a baseline liver and renal function panel, a
The
echocardiogram
question
and
was, the
ECG.
question was, what type of APML is this? Okay.
Yeah,
Rapid, it is hypergranular uh,
hypergranular
high risk
variants.
APML because you have only 9 minutes for the
Okay,
short question
right,
to see the blood film and to answer the all the question which is given under the third
right.
question.
Okay,
Then
so
they will ask you what is the immediate treatment.
immediate treatment would include admitting the patient, um, aggressive transfusion to correct the coagulopathy and thrombocytopenia, aiming a platelet count above 50 and fibrinogen above 1.5, starting ATRA at 45 mg per meter squared. Um, watch out for tumor lysis syndrome, watch out for differentiation syndrome, and if there are signs or symptoms suggestive of that, consider steroid treatment. Because this patient is high risk, we need cytoreduction with anthracycline in addition to ATRA. So arrange baseline echocardiogram, EKG, and liver and renal function prior to starting chemotherapy. This is a man. Ideally, we should discuss fertility preservation prior to chemotherapy, but in this case, because this is a medical emergency, we would counsel the patient that this shall override um, or if time permits, we can still arrange sperm banking, saving sample prior to starting chemo. And the baseline evaluation prior to treatment also includes virology screen for hepatitis B, C, and HIV and G6PD level, close monitoring of counts and coag, including fibrinogen and D-dimer during the treatment. If there are signs of sepsis, perform cultures and start broad-spectrum antimicrobials immediately. Yeah, I think that's pretty much I could squeeze in the 9 minutes
Will you
answer.
give this patient steroids?
So if I think there are two approaches in the literature, either prophylactic steroids or preemptive or or at the onset of detecting signs or symptoms of differentiation syndrome, Personally, I would prefer starting prophylactic steroids, given this is a high-risk case.
In high-risk case, we always give prophylactic steroids to prevent differentiation syndrome. Would you
Okay.
monitor electrolytes in this patient or not?
Yes. So close monitoring for the electrolytes for the possibility of hemolysis syndrome. So this include monitoring potassium, calcium and phosphate, blood gas, including pH and bicarbonate.
Potassium and magnesium are the one which are
Put,
important to
sorry,
monitor.
okay, so potassium, calcium, phosphate, pH,
And
bicarbonate,
magnesium.
and magnesium.
Magnesium. Yeah.
Okay, all right,
We will
okay.
check this twice daily. According to our protocol, we check them twice daily when we start for the patient.
Okay, right.
These will be the questions that they can ask you in 9 minutes. Other question they can ask you will be what are the side effects of ATRA in this patient. Then
Yeah, so for side effects, common side effects include headache, derangement in liver function, prolongation in QTC interval. Some patients might develop dermatological side effects, including rash, and in most circumstances, these could be mild and could be manageable. Um, and following treatment with ATRA, patient can also develop differentiation syndrome, which should be managed accordingly.
tumor cerebri, hepatotoxicity, and electrolyte disturbance. You already mentioned. So these are a few side effects that this patient can develop with ATRA.
Yeah.
Okay.
In
So this-
practice, they can also have derangement in liver function and
yeah,
prolongation in QTC,
yeah.
which is something that needs to be monitored closely for.
Yes, we calculate a QTC interval before every dose of ATRA and arsenic to the patient,
Yes.
almost every day for these patients. And electrolytes and the DIC profile every day as well.
Yeah. Can I ask quickly about the regimen in high risk and low risk? So for high risk, you give ATRA,
Plus
cyto
idarubicin.
reduction, and vancomycin, and do you also give ATO? I mean, arsenic trioxide here.
So a high risk patient would get arsenic plus idarubicin.
Arsenic plus
And,
idarubicin.
yes. And the
And
low
the,
risk patient will get ATRA plus arsenic.
so for high risk patient, they do not have ATRA.
For high risk patient, ATRA, the regimen is called IDA.
Okay.
ATRA plus idarubicin. ATRA is the first line.
Yeah. Yes. Okay.
If
Yeah.
you
Yeah.
see,
So
if
high
you see
risk
a
is
blood thin,
ATRA plus idarubicin. Okay. And
yes,
then
if you
low
see a
risk
blood
would
thin,
be. Mhm.
if you see a blood film and it says bilobe cells,
Yeah.
you have
Yeah.
to start ATRA.
Yeah. Exactly.
And on the same, if you can confirm PML RORA stain on the same day or on the next day, you can
Yeah.
add idarubicin or ATRA accordingly. Idarubicin for high risk patient when the white cell count is about 10, and
Yes.
arsenic for low risk patient if the white cell count is less than 10.
Right. So the arsenic trioxide is not used in high risk patient then.
No, no, no.
All right. Okay.
If
Fine. Okay.
if the patient is intolerant to idarubicin or very severe reaction happen, then it becomes second line. Then you do not have any other option. But the normal protocol in all our trusts are to start IDA in high risk patient,
Right.
and arsenic in low risk patient. Extra plus arsenic in low risk patient.
Right. And what dose of idarubicin do you usually use?
No idea. The
Okay.
pharmacist tell us, and no one will ask you doses in the exam.
Okay. Good. Thank you.
Okay. The doses that you need to remember for the FRCPath exam is only the DUX doses: apixaban, rivaroxaban, and rituximab.
Okay. Thank you.
Okay. So this is the third case. This is an 82-year-old patient who presented to emergency department with progressive fatigue. Okay. The full blood count shows hemoglobin of 69, white cell count of 4, platelet count of 200. The biomedical scientists tell you that this patient has likely TTP because he have seen schistocytes in this blood. This is power 10. Now power 50. Right. So this is the film of 82-year-old with fatigue and anemia. Anyone going for part 2 should report this blood film. Asif Iqbal, I can see your name.
Yeah. I can see that there are a fair number of schistocytes. There is a mild anisocytosis. Some target red blood cells are seen. I can see there's thrombocytopenia as well. And in the WBC, so far, I cannot see any abnormality. But there is a lack of polychromasia, so I don't know if I should mention that or not.
So this is polychromatic cell. This one and this one, this one. The big macrophages are present there.
Yeah, maybe.
Do you
So
think
yeah,
this patient has thrombocytopenia?
Yeah, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Not in this field. Yeah, in this field probably.
Yeah, again 8 to 10.
Okay.
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 Report the blood film. Let's see how you report it.
Yeah. So red blood cell, there is mild anisocytosis, uh, plenty of schistocytes, fragmented RBCs, more than 1%, polychromasia, and a few teardrops, few target red blood cells. And WBC is unremarkable. and platelet counts are normal. So my impression is microangiopathic hemolytic anemia. Yeah.
What can be the causes of? First, complete your report. Sorry. This was your impression. What will you suggest?
Yeah, I will suggest coag screen and coagulation screen and ADAMTS13 assay.
Why you are suspecting TTP in this patient?
Yeah, this is one disease that I need to rule out in almost every patient of microangiopathic hemolysis. Most likely in 82 years old, TTP is unlikely, but am I not supposed to rule out, TTP in every patient where there is a Maha?
Then it will become emergency. If you are thinking about TTP, then this is emergency.
Right. It's not TTP because platelet counts are normal. I'm so sorry. I will do the coax. Yeah.
What investigation you will like? What suggestion you will do? You have seen the blood film. You have done the impression. Okay. You have to write something in suggestion, because otherwise the team will call you, doctor. You have reported the blood film. What should we do?
So the differential diagnosis in a 92-year-old with Maha would be a mechanical heart valves. It may be a solid tumor malignancies causing like a liver tumor or something. It may be a infections causing DIC. So we need to rule out this these causes. So we will have to do a coagulation screen, a CRP, blood culture, a CT scan of neck, thorax, and abdomen, and an echocardiography.
About hemolytic screen?
Oh yeah, I have to do a hemolytic screen as well. That urine for hemoglobin and reticulocyte count and LDH.
First, you have to do hemolytic screen to rule out whether this is immune or non-immune. The blood film shows red cell anocytosis, multiple schistocytes, polychromatic cell, platelet counts are normal, with few platelet plug scenes, normal white cell count. The impression is likely hemolysis, Maha or hemolysis. The patient needs to do hemolytic screen, hematinic screen, and the coagulation screen, as you mentioned. You have correctly suggested that this can be a well-related hemolysis. And the next question can be in the exam: what are the different causes of Maha?
Okay, so that questions will be age specific. So if it is age specific, then I will go with a malignancy, then mechanical heart valves, then infections with DIC, and then autoimmune causes.
Also mention infection, malignant hypertension, hemolytic uremic syndrome, TTP, which can be primary or secondary. Even in this age, it is possible as well. Drugs induced as well. Right. So, what treatment would you advise?
Yeah, that will depend upon the cause of the Maha.
Yes, patient is having hemolysis. Would you advise something in terms of treatment or not?
Yes. So while awaiting the investigations, we first have to know if the patient has an autoimmune hemolysis or not.
A non-immune hemolysis. For example, the hemolytic screen came out as negative, and this patient has a heart valve which was inserted in 2000, and there is a valve abnormality. Okay,
Right.
but now this patient is hemolyzing. What treatment would you advise? The changing of the valve may take a week.
We may have to discuss this case in a multidisciplinary meeting along with a cardiologist and a cardiothoracic surgeon. And the patient is symptomatic with anemia, so he will need blood transfusions. But we need to arrange a replacement of the heart valve as soon as possible.
You are not the one to arrange replacement of the heart. This is the cardiology job. This patient is hemolyzing. The doctor is asking you, what should I do for this patient? Blood transfusion, okay. What else?
Hematinics, folic acid.
Folic acid, what else? So blood transfusion, folic acid, VDE prophylaxis for this patient because hemolyzing patients are at high risk of
Right.
thrombosis as well. Okay.
Right.
So if I'm prompting you like this in the exam, if they prompt you in the viva, for sure they will fail you. They do not like prompts in the exam.
Right.
Okay, so with mechanical hemolysis, an 82-year-old patient, these can be the few questions. Report the blood film. What are the causes of Maha? What treatment would you advise, or what investigation you would like to do? What treatment you will advise? These can be the questions for 10 marks in short morphology. Yes.
Right.
And if the patient is young, 40 or 30-year-old, then likely you can think about a TTP case if there is thrombocytopenia or if they have given you any supportive investigations like renal function. But in elderly patient, it will be either mechanical hemolysis or it will be uh, secondary TTP. In secondary TTP, you are not required to do the um, uh, discussion with the TTP consultant. Let's go.
I, I just want to ask a question. In this, that the last film that we have shown is probably borderline for thrombocytopenias. Uh, maybe the platelet counts is around 1 to 1.5, maybe 1.5. So does that rule out TTP? I mean, we cannot say TTP without thrombocytopenia.
The last film has a lot of platelet plugs. The platelet count was about 200.
Okay.
Okay,
Okay.
platelet count was about 200 in this patient, and you yourself calculated there were 8 to 10 platelets in each field. So that cannot be thrombocytopenia.
Right. Okay.
So this is another 30-year-old patient who presented to emergency department with epistaxis again and fever as well. The full blood count shows uh, hemoglobin of 120, white cell count of 16, and platelet count of 40. This is the power 10 blood count. Right. Another volunteer. Okay, who is next?
Hello. Can you please repeat the stem of this question?
Is a 30-year-old female with fever, flu, and epistaxis. Full blood count shows hemoglobin of 120, white cell count of 16, and platelet count of 40.
Okay, this, the peripheral blood film is showing abnormal cells, abnormal, most likely blast cells scenes that are very medium to large in size, and the cytoplasm is pale, basophilic, and agranular, and the nucleus is uh, uh, nucleus is uh, has a variable in shape, and okay, so nucleus is variable in shape, have a partially condensed chromatin with a visible prominent 1 to 2 nuclei. With a mutation, blast cells. Okay, and the neutrophils were evident in the field. The nucleus of indentation in the cells. So the red blood cells are normochromic normocytic with mild anisocytosis. Few acanthocytes has been seen, and the platelets are low in number through thrombocytopenia. So my suggestions will be the differential diagnosis. It can be acute leukemia. Okay. The differential is acute leukemia in this patient. And
Do you think these are blast cells?
yeah. Yeah, abnormal cell. It can be a typical lymphocyte, but there is a visible nuclei.
Atypical lymphocytes can have visible nuclei as well. No.
Abnormal monocyte. This is an abnormal monocyte with a wide variation, low NC ratio, pale visible cytoplasm in the vacuolation and vacuoles in it. This is an abnormal monocyte.
This patient has a lot of mature neutrophils. What about this side?
Atypical lymphocyte cells. with the scalping around the RBC.
So how would you report this blood thinning?
Okay, so the abnormal lymphoid, atypical lymphoid cells, cell scenes with abnormal monocyte as well, and the patients have neutrophils are evident, with red cells are okay, and acanthocytes and true thrombocytopenia. It can be uh, infection, fever. It can be infectious mononucleosis with abnormal lymphocytes. Fever.
Yes, why the patient has thrombocytopenia?
Infection related, can be infection. True.
Yeah.
I cannot see granularity. So again, there's a abnormal lymphocytes that are scalping around the red cell, and there's evacuation. There's no granulars, not granular, very granular cell.
So scalping does not mean always that this is abnormal lymphocyte. Scalping can be present in leukemic cells as well. Last week, we have shown you one blood film of monoblastic AML in 19-year-old, which is still present on the channel. I forget which one is the quiz number, but that blood film contained blast and thrombocytes, etc., and it has scalloping as well. But here you can see the nucleus is a bit mature, and the cytoplasm is quite a lot bluish. Patient has fever, flu, and thrombocytopenia is secondary to uh, infection. So what investigation would you like to do in this patient?
So the investigation can be the baseline investigation UC, LFT, CRP, and in fact for infectious mononucleosis, we will rule out for monospot test and uh,
Virology, hepatitis B,
yes,
C, and HIV as well, and EBV PCR or serology,
PBPCR.
whatever is available in your hospital. What is the treatment?
The treatment is symptomatic. The treatment is symptomatic, and if the patient having superimposed bacterial infection, then we will have antibiotics as well. Otherwise, there is symptomatic treatment.
What about epistaxis?
For epistaxis, there will be general measures and the hydration and the tranexamic acid.
Okay.
And it can be need a platelet transfusion in severe cases.
Patient is bleeding. The patient may need platelet transfusion, local measures, tranexamic acid, and symptomatic treatment in forms of antibiotics for the infection. Or if you do viral throat swab in this patient, if flu is positive, then you can give them Tamiflu as well. Okay. Right. So this is the last case. This is a 56-year-old male patient with long-standing anemia and tiredness. His full blood count shows hemoglobin of 90, white cell count of 11, and platelet count of 120. This is power 10. Over 50. This may be a bit tough case, but anyone want to try on this? Anyone? The last case?
Okay. What was the age of this patient? I would like to try
56.
50. Okay, so 56 with biocytopenia, right?
With low hemoglobin, white cell count was 11, and platelet count was low.
So these are the abnormal lymphoid cell scenes.
Mm-hmm.
The abnormal lymphoid cells was seen. There was medium in size with a low ANC ratio, intermediate to low ANC ratio, where the nucleus was clumped. No visible nucleoli has been seen, and these are the atypical. Few lymphoid cells are large in size with a low NC ratio. Otherwise,
Mm-hmm.
okay, say this is a low NC ratio. The nucleus is round to oval with the no visible nuclei. And there is a true thrombocytopenia, while the red cells are anisocytosis, teardrops, elliptocytes, and acanthocytes has been seen. There are some microcytic cells have been seen. This is a monocyte. How's the neutrophil? I cannot see the neutrophil in this.
Neutrophils were low, lymphocytes were high.
Okay, so there's neutropenia. So suggestive of some lymphoproliferative disorder.
Can you identify this cell?
Abnormal cell. Oh, totally abnormal cell. It looks like a blast cells, lymphocyte blast cells, lymphoid blast. Like
What?
small was deep basophilic and visible.
What about this?
This
Baker's
is
syndrome? This case is not a bit straightforward.
so this is a reactive plasmacytoid lymphocyte-like cells, like because the central deep basophilic cytoplasm and the eccentric placement of the nucleus.
Hmm. Right. On flow cytometry, they were 24%. Another one. So what do you think is going on in this case? Can you hear me?
Yes, I can hear you, but I'm really not very concluded in this patient. Some cells are plasmacytoid. This is a plasmacytoid,
So
not audible.
why are
This
you
is
calling it plasmacytoid? Why not plasma cell?
okay. Um, back in my mind running, there is an abnormal lymphoid. Okay. So this can be plasma cell, no doubt.
This is plasma cell. This cannot be. Don't say this can be. This is plasma cell. And they were 24% on the flow cytometry.
Yes. Then if they are more than 5%, this is probably plasma cell leukemia.
Yeah, this was a case of plasma cell leukemia. We picked up late because they are not so frequent in the blood film. The quiz number 1 on the channel is also plasma cell leukemia, but that film is full of plasma cells. It was very easy to pick that one, but this patient has very scattered plasma cells in the peripheral blood, and he was febrile as well. We thought that there may be one plasma cell on the thin side, where it may be a reactive one, but on the thick side, he has many plasma cells. And when we did the flow cytometry for this patient, it came out that he has 24% plasma cells in the peripheral blood. What is the first line treatment options for this patient?
Body-based therapy and rituximab.
Sorry, can you say again?
First line treatment option. In the plasma cell, we have to based body-based therapy, bortezomib-based therapy.
If you say like this, you will fail the question. Carmen, what is the first line treatment options for plasma cell leukemia?
Well, so I think the decision would be what we is it daratumumab based in a quadruplet treatment, daratumumab, Velcade, thalidomide, dexamethasone.
Yes, in UK we treat the plasma cell leukemia on the line of multiple myeloma. But when you answer this question, you will say the treatment options are according to transplant eligibility or non-eligibility.
Right. Okay. Yeah, depending on whether this is a transplant eligible or non-transplant eligible.
He is young, he is 56,
He's young. Yeah.
but he may have other comorbidities. So you will say either transplant eligible or non-transplant eligible. If this patient is transplant eligible, then I have Dara UTD protocol. If this patient is non-transplant eligible, then I have these options for this. Then your question will be answered.
Right. Okay.
And they can ask you what are the high-risk cytogenetics in multiple myeloma or in plasma cell dyscrasia.
So the high-risk cytogenetics include amplification 1q, translocation 14, is it 14?
16?
16?
14, 16?
Yep. And translocation 414, deletion 17p, and translocation 1420.
Yes. Right. The last question they can ask you, what bispecifics are available for multiple myeloma currently in UK?
Okay, so the bispecifics that I know of include elranatamab and teclistamab. Which in where I practice, they are available as a under compassionate program or self-financed item from third line onwards, and these patients have to be triple class refractory. But I have to confess that I don't know if they are available in the UK.
Which one?
Teclistamab and elranatamab.
Yeah, we use them regularly. Even district hospitals are using elranatamab.
Okay.
Tertiary hospitals are using teclistamab, talquetamab.
And both are available, right?
Yes.
Okay. And how do you choose between these bispecifics and CAR T therapy in
CAR T has been stopped for multiple myeloma.
Sorry?
CAR T has been stopped for multiple myeloma.
Oh, is it?
I think none of the tertiary centers are doing CAR Ts now for multiple myeloma. They are offering bispecific to their patients.
Okay, I see.
Mostly it is the elranatamab because the safety data is good. But on trial, the patient are also getting teclistamab, talquetamab, belantamab is also available, but because of the keratopathy related side effects, most of the consultants are avoiding it. But it is still available. Work is going on belantamab, and maybe next year you will see belantamab is second line.
Right. Okay.
Yeah. Because myeloma is a very evolving topic. A lot of things are coming in it.
Yeah.
And yes. So remember the first line options for plasma cell dyscrasia. Remember the names of the bispecifics.
Yeah. Can I ask, sorry,
started
just one
Mhm.
question for belantamab. Do you classify it as a BCMA conjugated with cytotoxic? So is it still classified as bispecific or not?
I think BCMAs come under that bispecific.
Yeah, so belantamab is a monoclonal antibody against the BCMA, which is conjugated with the NMAF, right? So
Mhm.
can we classify that as an antibody drug conjugate instead of a bispecific agent?
I think so. You can classify it in that way. It is in my belantamab. It's a monoclonal antibody.
Yeah.
It's not bispecific. It's
So
BCMA.
bispecific would be tacutamab, iranatamab, and teclistamab, three of them, right?
Yes. So elranatamab is bispecific.
Yeah.
Then
Teclistamab and tacutamab.
telcutamab.
Yeah.
This one.
Yep.
Teclistamab.
Yep.
This one.
Yeah, agree.
And there is any other. No. No.
That's the three that I know of, to be honest.
Yes, these three are the.
Yep. Okay. So the current so for transplant eligible fit patients, in the case of plasma cell leukemia, do you treat them as high risk disease and therefore uh, sort of a do you choose triplet or quadruplet?
Or triplet, just like multiple myeloma, and we transplant them if they are transplanted.
So
Um,
quadruplet.
yes, DARA DVTD.
DVTD, yeah, that's what I
Yeah,
use as well. Okay, great. Dara VTD, good.
yeah. And if
Okay,
they
and
are not transplant eligible, then you have other options like
so
DRD,
yeah,
Lendex,
yep,
Velcade, dexamethasone,
mhm,
or VCD, simply
yep,
botulinum cyclophosphamide dexamethasone. These
yep,
3 or 4 options for
right.
um, transplant ineligible.
Yes. And for the transplant eligible ones, do you also do consolidation therapy post transplant
Yes,
and the
same
maintenance
medicine,
therapy? Same. Okay.
same, yes.
Okay,
Lenalidomide
thanks.
maintenance in the end, and same protocol that we use for multiple myeloma.
Yes. Okay. Thank you.
Right. So this was